What is that for? Is it just like if we want it to be there? No. No.
So every SBBL, once you complete that.
So it's like the cases?
Yes. It's the case study like that, yeah. Yes. And you guys do your presentations. You guys pair up. You guys paired up in hearts as well?
Finish out the day. All right.
Keep pushing through. You have to just, some days you just have to, when you start looking ahead, it gets overwhelming. You almost have to just look down and just watch, okay, I'm taking this step, and then, so, you know, one test to the next test, to the next test, to the next test, and then before you know it, you look back and go, wow, look what I did. But when you look up and you think about, holy crap, I'm going to be doing this for the next how many months and years, it can get overwhelming. So today is all about, now we're about aortic aneurysms. It's all that matters right now. All the other stuff will come. You're going to be giant cell arteritis experts. I hope so. But I hope that you think about that lecture 2 years from now when you see it. I hope it, you know, there's some kind of recall so that you can make that diagnosis. Are there times when the physician doesn't know and you know? Oh, yeah.
Feels good.
Wait, you don't know? Oh, let me help you. It happens. Absolutely it happens. You know, there's sometimes you go, how did you get medical school? But then there's other ones that are not. And there's PAs that you look at and go, how did you get through PA school? I didn't even know this. You say that in your mind, though. You never say that out loud.
Right.
But there's good and bads of everybody. So don't rely on someone else. It's going to be you. That's why you're making the big bucks and you want to wear the white coat. Right? It's going to be you. That's it. That's it. Got to know it. All right, aneurysms. How much experience do you guys have with aneurysms? Seen them?
It's the one in me.
Okay. Good, good, good. So it's a big puffy thing in one of the arteries.
And sometimes you can see them on ECGs in the heart.
Yes, you can. So sometimes you have these and don't even know you have them. And years go by, and all of a sudden you're in the ER because you're constipated and you're a good PA and you order a CT of the abdomen with contrast. And all of a sudden, holy cow, look what we found. And then you get to be the one to put that white coat on, walk in that room and sit down and tell them, well, you have constipation, but you have this other problem. Gonna happen. How do you do that? How do you give a patient bad news? Good luck with that. There's not a good way. Good luck with that. All right, two different types. Fusiform, vascular. Fusiform involves the whole circumference. Vascular makes us not that hard. All right, so, well, there's these different classifications based on the renal arteries. Are the renal arteries important? Yes. The kidneys will tell you so much. Have you ever heard of a Foley catheter being called a poor man's swan gans? You ever heard that before? Anyone know what a swan gans catheter is? Okay. That's another day. But the kidneys, if they're not perfusing, something's wrong. And it's usually the first thing that shuts down. Okay? The first thing that you see once they start going south. Oh my God, what's wrong with the kidneys? Okay? Seems like that's where it always lives. All right, so there's this classification, then, next to, underneath, infra, all that different classifications. All right, who gets it? Well, you gotta be at least 50 years old. Is that right? So if you're 49, are you safe? It's just a general estimate. Dudes are in trouble though. Dudes get it more than women. 5 to 1. Crap. I'm in trouble. All right, so we're greater than 15,000 deaths for 10 leads gone. Okay, great. Risk factors. Older age, male, family history, first degree relative. Okay. My father has died from an aortic aneurysm. My grandmother on my father's side died from an aortic aneurysm. Isn't that exciting? Y'all are all like deer in the headlights. Like, he's screwed. So we all have to. We're all going to have. You're going to realize your family history and go, oh God. If you haven't diagnosed yourself with 5 or 6 things, you will by the end of PA school. You'll have diagnosed yourself with a brain tumor and all kinds of other horrible conditions where you're off to the doctor. Doc, I just learned about this in clinical med. I need to make sure I don't have it. Chances are you don't. But could you? Well, yeah. Okay. Genetics, big deal. Okay, so what if I came to your clinic? I'm just here for a checkup. I'm just here because I'm 46 years old and I need to, have my blood checked. And what would you do? So you look at my questionnaire and you see that on my history. What would you think? What would be your recommendation to me? Any thoughts?
Live it up to your 50.
Boy, that is awesome. Yes. I'm going to go out and start smoking and drinking right now. Well, you would educate me to my risks. Am I high risk? Yes, I am. And so, would you want to see me on a regular basis? Yes. So, again, there's not much you can do other than preventative and saying, okay, it's imperative you go see the doctor on a regular basis. It's not just when you're sick. And this is why. Okay? And this is where that education comes in, to teach your patients of, no, I'm not just wanting to charge you a copay just to charge you a copay to tell you that you're healthy. I actually want to make sure that you continue to stay healthy. Okay, so what else could you make sure I don't have?
How does Marfan Syndrome affect this?
Oh, we'll get there.
Okay.
Jumping ahead, excited, all right. Good. What else? Okay, so I'm in your clinic. I'm your patient. My father died of it. My grandmother died of it.
You probably want to check your abdomen and make sure you don't have it, or start to have it.
Okay, how could you do that? How much does that cost?
Too much. Your insurance. Your insurance.
I have a $3,000 deductible. How much? Okay. Another thing you could check is my blood pressure. How's your blood pressure? What would treating hypertension? So you want to make sure I don't have hypertension, right? Because hypertension would be bad. So you'd monitor their blood pressure. You would want to check my cholesterol, which, happy to report, blood pressure is 120/80, and my cholesterol is, well, it could be better. My HDLs are a little bit low, but other than that, everything else is good. Bad cholesterol's low. That's good. Marfan Syndrome. What the heck is Marfan Syndrome?
It's where you're long basically.
Does he have it?
No.
Okay. Typically, it's going to be your NBA
I was going to say.
players. It's your basketball players. Okay. Everybody's got this thing going on, but they don't know what this means. Okay. So, if your reach is longer than your height, you probably have Marfan. Okay? Oh my God. Everybody check. I see her in the back, she's doing this, she's doing some side things. Wait, I gotta measure on the wall. Marfan's is a connective tissue disorder. So are there connective tissue in your vessels?
Yes.
So it makes them a higher risk for aneurysm. So do you think it's good for an NBA player that has Marfans to play professional basketball, football? No. Done. Hang up the shoes, because it's not like a torn ACL. That's so it just makes him higher risk. Okay, so let's go to the emergency side. You got a patient that's coming in by ambulance who's extremely tall, involved in a motor vehicle accident. And they say, oh yeah, by the way, I got Marfans.
You're like, oh yeah, by the way, you're in the CT.
Yeah, don't just keep on going with the ambulance stretcher right to CAT scan. Don't even stop it. Okay. Other risk factors: polycystic kidney disease. You'll learn about that if you haven't. Okay. 80% of the time atherosclerotic, 5% of the time inflammatory, trauma, staph infections, TB infections, connective tissue disorders. That's the Marfan. Okay, that's where you get these. All right, so vascular inflammation, degenerative disease. All right, you got all these inflammatory markers that screw everything up, make the vessel weak. Okay. Starts a big balloon, okay? It's gradual. You live your whole life and you don't even know it. Until one day, all of a sudden, it starts to dissect. And then you start having problems, okay? So, aneurysms tend to expand over time. T, which is wall tension, equals pressure times radius. You remember that from phys? Ugh. One of those things you want to forget, right? I hoped you would never see it again. Well, unfortunately, it's one of those things that contributes to this. That's why hypertension, making sure my blood pressure is good, is important. That's why I don't want to have diabetes, right? Diabetics have screwed up blood vessels. All right. So, let's see. One of the first times my dad went to the ER, he was screaming and hollering, being belligerent. Quite embarrassing, actually. But he literally was in so much pain. He could not stay still. He was just... So when you work your ER rotation, or... because this is where you're going to see it. You're not going to see it. They're not going to schedule an appointment 2 weeks out and see you in family practice. They're going right to the ER. So when you do your ER rotation, this is when you see this patient, okay? They're flopping around on the bed. They can't get comfortable. They're screaming and hollering. Well, those beds aren't really comfortable to begin with. They're kind of meant to be temporary beds, but it's continuous. It's gnawing, it's burning. Something's just not right. Their exam is out of proportion, okay? They're just hurting. So pulsatile supraumbilical mass. Can y'all palpate your aorta? I can. Does that mean I have an aneurysm?
Probably.
Well, let's just go.
We need to work on
No, but people that have thinner abdomens, you actually can palpate an aorta, and it's very normal. Don't freak out the first time. You know, you're laying in bed and all of a sudden, oh my God, I can palpate my aorta. It's an aneurysm. Sometimes that's normal. So we have to look at it further. So just palpation alone doesn't mean you have an aneurysm. Don't scream aneurysm the first time you palpate someone's belly and you can feel their pulse. Okay. So, is it very common to find it in physical exam? 30 to 40% of the time. So 1/3 of the time. Of patients that actually have it, you can feel an enlargement so significant that just even light palpation, you can palpate it. Most of the time, you have to kind of push in a little bit to feel it. I'm just talking about literally just this much, and it's pulsating. All right, so encroachment of the aneurysm can cause gastric outlet obstruction, renal obstruction. So does this mean they come in with other complaints? And you find this accidentally? Oh man, yep, exactly what that means. So you can find cancer. I have found many of cancers, many of masses, many of anything pushing on a ureter that has caused the kidney. All of a sudden, you're doing routine lab work and they have creatinine of 3, and you're like, what the heck's going on? Something ain't right here. So we got to find out. And they have an elevated creatinine, and you can't give them contrast. Anyways, so these can happen, so look for them, okay? Vertebral body erosion, so your aorta is right in front of your spine. You remember from anatomy. So very common to see this, it erodes into it. So lower extremity ischemia, secondary to a thrombus. All right, so how do we work them up for an aortic aneurysm? We want to do a typical abdominal workup. Any patient that comes into your office or into the ER or wherever you're seeing them, and they have abdominal pain, you better order every single one of these labs. And if your preceptor says, okay, we got a patient with abdominal pain, what do we want to order? You better be able to spout this one off in about 2 seconds. Because this is like your average abdominal pain workup on everybody. Except in females, you want to add a pregnancy test. Okay? So CBC, CMP, there's that CMP again. UA, amylase lipase. Amylase lipase, what's that tell you? Pancreatic enzymes, which one's more specific? Ooh, that's a guess. No, lipase is the more accurate representation.
I had 50-50 chance. She stuck
Get a 50-50 shot. At least you tried.
Exactly.
I don't care if you're wrong in here. Is it okay to be wrong in here? Well, not on a test. But in lecture, yes, absolutely. Nobody cares. Just try, okay? Don't sit there and be afraid to talk up. There's that pharmacology word again. Can't get away from that thing. Beta blockers. What's beta blocker?
It blocks beta receptors.
Block beta receptors. It's all your LOLs, your LOLs, right? So beta blockers, they help reduce the rate of expansion. They're going to control your heart rate. All right, that's what you're looking for. Your low pressure, metoprolol. Statin therapy. So you want to make sure I don't have high cholesterol. If I do, you're going to put me on statins, right? Statins the first round. That's what is most commonly prescribed. Aspirin. Okay, I think we get that one. This is not during an active dissection. This is treatment of an aortic aneurysm. Understand the difference, okay? Doxycycline. I don't know how that got up there.
I was going to say, that's a new one. I'm going to take that.
Scratch that off of your thing. Sorry.
Everybody gets an antibiotic.
Oh, I wait to hear this one. Let's see what kind of phrase he comes up with here.
Just see if you guys were awake is what that was.
I mean, like, I can see like TV drugs.
All right, make sure I don't smoke, make sure I got lipid control, make sure I exercise, make sure I eat good, eat my salads, not chicken fried steak because it's chicken. All right, surgery. It's pretty much the only option, right? So if I have an aneurysm, does that mean I have to have surgery? Not necessarily. Depends on how big it is. Okay. Sometimes it's like, okay, you have this aneurysm, it's X amount of size, we're going to see you in a year and recheck it. Or we're going to see you in 6 months and we're going to follow this and make sure it's not growing. So if you have consecutive scans over a 6-month time with no change over a few years, then it's safe to put it back a little bit and say, okay, we just need to continue to watch this and make sure your blood pressure and your cholesterol is good. Okay? So here's how they repair it. Put this mesh in, okay? And the mesh basically acts like the aortic wall, okay? So now it can handle the pressure in place of the aortic wall. Yeah.
So in patients who are high risk, like you are, would you want to have like lower levels of blood pressure than standard, or do you just want to not see hypertension?
That is an excellent question. You know, in diabetics, Have y'all talked about blood pressure and hypertension?
Yeah.
Okay, in diabetics, we treat them differently, don't we? Okay, in this one, I probably would. Probably treat them a little different. Is it wrong or is it right? I don't know. In somebody like me who's high risk, I probably would be a little bit more aggressive if I can tolerate it. If I was 140s, 150s. Now, you guys understand when you want to see hypertension, you tell me what? You tell me to go home, and you take my blood and take your blood pressure the same time every day for a week, 2 weeks, and write those numbers down and bring them back to me. That means more to you. That should mean more to you than when I come to your clinic because I'm freaked out because, crap, I might have an aneurysm and my blood pressure is 150 over 90. Okay, does that mean you need to write me an ACE inhibitor? No, just have to get the bigger picture. But good question. I would probably be more aggressive. Elective repair. Okay, so 5.5 centimeters, the threshold for repair of an average patient. Younger, low risk? Maybe you'll sit on it. Maybe you'll just watch it. Maybe you'll rescan it. Okay. It's always better to get a second opinion, second set of eyes on this. Probably want to be involved in a surgeon, cardiovascular surgeon, general surgeon, getting their opinion on it. They're probably the ones going to follow it unless you are the PA, that surgeon. And you'll be seeing a lot of these. And you get really good at it. Okay? So asymptomatic ones, small, we're just going to watch them. Going to scan them every few years, every 6 to 12 months. Make sure it doesn't change. You're looking for change. So when you order a CT 6 months from now, you're saying, okay, well, it was 5.5 centimeters 6 months ago, and today it's 5.5 centimeters. So that's good. It's not 6, it's not 6.5. We're looking for change. Okay? Higher risk for rupture. You've got to change. Smoking, severe COPD, poorly controlled hypertension. Yeah, that gets it. And that was my dad. He did not think his blood pressure was anything, and he smoked like a freight train. So, but does that mean I'm not going to get it? I've never smoked. You know, I'm not really in that. I've just never caught smoking because of my dad mostly. But does it mean I'm not going to get it? No. But those things just make you at higher risk. It's all about stratification and risk, okay? That determines how you treat your patient. Look at the whole picture, get the whole background, okay? Everybody's different. All right, recommend one-time ultrasound. Men of 65 to 75 who have ever smoked. Siblings, offsprings, 60. Screening not recommended in women. That's because, remember, it's 5 to 1 men, right? All right, shock, hypotension, pulsatile mass, abdominal pain. Ugh. These are big, scary things. Don't scream down the hallway because you don't want their blood pressure to go up higher. I'll be right back. One of those things, okay? Then you're calling everybody and getting them help immediately, okay? Does that mean they're bleeding out in their belly? If they're bleeding out in their belly, they're about to code on you, and there's not, even if the surgeon was right there, there's not anything that you can do for that. Okay, these are dissections, and we'll get into that in a second, okay? So syncope with cardiovascular collapse, look at that mortality. 25% die en route, 50% die before intervention. Yeah, 30-day survival is 11%. Live it up till I'm 50. Any questions so far? All right, thoracic aneurysms. All right, so there's your thoracic aorta. Typically you don't see these. In fact, you're going to find, if you find a thoracic, you're in Hodunkville, USA, Oklahoma, paying off your loans, and you catch one of these, and it's a thoracic aneurysm, and you call Oklahoma City, and you're like, I got this patient, blah, blah, blah. And they'll be like, thoracics? I don't do thoracics. You got to send them to Timbuktu, USA. The only place I know of that does thoracics is Houston. No, you gotta fly them to Houston. That tells you how common this is. So you got big major problems if you've got a thoracic aneurysm, okay? There's not very many surgeons that deal with these because bad outcomes. Live it up, enjoy your life, you're gonna die.
So is it harder, I shouldn't say harder to get one, is it less common to get one of these because it is surrounded by so much stuff kind of keeping it more compressed?
It's not that it's less, it is, you typically see these more abdominal and iliac, that's where you typically see these. I've seen these before, but it's just, I think it's just because of gravity, to be honest with you. That's my theory, but I don't really have a, you know, other than that, it's just a theory. But you just don't see them very often. Sometimes I think, well, where are our sensors for our blood pressure regulation? Where do they attach? I hear a lot of mumbling. Right on the aortic arch. That's where your detectors are. So it makes me think, well, that's maybe why. That's where it's regulating the fastest. Okay. So if you have a thoracic, that's what they're going to want to know. Where the heck is it at? Is it ascending? Is it descending? Is it in the root? Does it involve the subclavian? Does it involve the carotid? Does it involve, you know, and so, I don't know, it just says, it said it on the radiology report I'm reading, you know. All right, have you guys had x-ray class or education? Some, a little bit? Yes?
Embedded.
Yeah, a little bit, okay. We're gonna look at some films here in a little bit and we'll kind of go. But, on your chest x-ray, you lose your aortic knob, okay? And it's in red, so that's important. So patients with chest pain, this is why they get a chest x-ray. There's a lot of causes of chest pain. And a dissecting thoracic aneurysm is one of them. So a widened mediastinum, loss of the aortic knob, okay? These are findings where you have to take one more step and order a CT. You will not be able to pass go or collect $200 until you get the CT. That is the best way to image this, CT angiogram with contrast. You can get transesophageal echo, transthoracic echo, that kind of thing. But most of the time this is incidental. Early diastolic murmur. Have you guys gotten murmurs over yet? Golly, those things are, you're going to learn them for the test, you'll have them on your boards, and if you don't do cardiology, you'll forget them. But just listen to a lot of hearts, and if you don't hear lub-dub, there's a problem. That's all I can tell you, okay? All you can say is, I hear a murmur. Well, what kind of murmur? Well, it's a grade 2, systolic, pre-ejection, murmur. No, just, I hear a murmur, okay? There's that cough, hoarseness. Okay, patient comes in with chest pain and hoarseness. Thoracic aneurysm is on your differential. Okay, vagus nerve. All right, treatment. Get him to a surgeon. Open repair. All right, deploy the stent. So you got the aneurysm. They put the catheter up in there. That stent is teeny tiny like that. As they deploy it, it starts distally and opens up throughout the whole thing, and that's how they get that whole stent deployed. Okay? Keep the blood pressure low, beta blockers, ARBs, ACE inhibitors, and then annual imaging recommended, even with repair. Still want to check it. Okay? Repair doesn't mean that it's permanently fixed. Now that we've identified the aneurysm, is it dissecting? Dissection just sounds like a bad word, and it is. This is true life and death emergent situation right here. Okay. Now, what can you do as a PA for someone with a dissecting aneurysm? Any thoughts before we even get into this?
Call someone.
Call someone, and after that, we're going to get their blood pressure right, because T equals that physiology thing, back, tension, heart rate. So we got to make sure their blood pressure is good. All right, so it begins to tear, and they create this false lumen. So what it does is it separates between the endothelium and the intima layer, and all of a sudden, there's so much pressure being fed that it just opens up and blood just starts moving down this false lumen, okay? And then you have this, you've got this aneurysm that just spreads, okay? And as pressure increases, that aneurysm is going to get bigger. Well, what's going to happen to that false lumen? It's either going to A, occlude the true lumen, and then there's no blood flow, or it's going to rupture. Okay? Yeah, I think I got everything now. All right, so here's a kind of a cartoon of it. All right, do you see that false passage, that false lumen? So it just creates a weakening in that endothelial lining, and the blood just goes and it separates out. Okay, and you're going to have, you know, this false lumen. They're going to have severe chest pain. Typically, they'll say it radiates through into my back. Chest pain through into my back. And that's because the thoracic root is radiating down behind the heart into your back. So I'll typically say it hurts into my back, severe. Are they going to always say the textbook ripping and tearing? No, it just hurts like you know what. So just pay attention to that. It needs to be on your differential. When you see a patient with chest pain, what's your differential? Well, if you don't say aneurysm, I'm going to wonder where your brain is, okay? Because you got to make sure. So that's why we order it. Chest X-ray. Want to see that aortic knob? Want to see the outline of the heart? That's all good. No pneumonia, no nothing. Okay, good. They're good. All right. Back pain, like I said, radiates into their back. Abdominal pain, you can have dissections. Again, pain out of proportion. That's what we're looking for here. Okay. Risk factors. I think we've hit all of those risk factors. Coarctation, crack cocaine. Yes, people do crack cocaine. It's really stupid. Cardiac tamponade. Everyone know what that is?
Yes.
Okay. You ever heard of Beck's Triad? Ooh, that one's going to be a test question.
Yes.
Is that later? They haven't had it yet?
No.
Okay. Beck's Triad is the triad of a pericardial tamponade. Jugular venous distension, muffled heart tones, and narrowing pulse pressure. So now when you get that lecture, and they say, what's Beck's Triad? And you go, oh, I know what that is. I hear a lot of typing, so get that one down.
Repeat it.
Jugular venous distension, muffled heart tones. When I mean by muffled heart tones means, I ain't hearing nothing. Are they alive? They're talking to me, but I'm not hearing much. Okay? Narrowing pulse pressures. Narrowing pulse pressures means 90 over 80. That's a weird pressure, isn't it? Narrows the top number and the bottom number, systolic, diastolic, start coming together. Okay? Beck's Triad. Bonus question on the test, maybe. You'll get it. You need to know that. Hemothorax. Any ideas why left is more common than right? All right, 20 millimeters of mercury difference in blood pressure between the arms. Absolutely, especially if it involves that subclavian on that side. If it's distal to the subclavian, because you remember your anatomy. Neurological deficits and renal insufficiency. Those kidneys, man, they're in everything. How do we make this diagnosis? So we've got this chest x-ray, we've got the loss of the aortic knob, why do you need a mediastinum? You're gonna hear me say that a few times. Order a CT, now we got this aneurysm we gotta figure out what to do with. Well, that is an automatic trip to the ICU. Do not pass go, it doesn't matter what's going on. If they have a dissecting aneurysm, they are going to the ICU. Happening now. Because they need their blood pressure controlled, they need monitored, and they're going to need surgery. Okay? Pain control with morphine. Morphine is a great drug for this. All right? The reason why is because morphine drops their pressure. And so a patient who's really freaked out, has high blood pressure, what are we doing on top? I got to hurry up. Morphine's going to drop their pressure, so you'll find that sometimes just treating them with morphine is enough to get their pressure under control. But then we got to get the LOLs in there. We got to get the beta blocker in there. Esmolol, write that one down. Esmolol is probably the best one. And the reason why is because it's drip and it's a short half-life. So you can titrate their pressures a lot better by hanging Esmolol. Okay? Esmolol drip. Not going to tell you the dose. Don't worry about dose. All right? So we're going to, oh yeah, there it is, Esmolol. So if they can't tolerate beta blockers, or if they have contraindications, contraindication to beta blocker? Lungs, think lungs, asthma, COPD, those type of things, big contraindications for beta blockers. I mean, they don't get them? No, but probably need to think about something else. Verapamil, Cardizem. Nipride, nitroprusside, that's another good one to use. That is an arterial dilator. Okay? Nitroglycerin is a venous dilator. Nitroprusside is an arterial dilator. That's why nitroprusside is the better choice in aortic aneurysms. Because nitro drops their pressure, right? Drops their vein to cava pressure. Doesn't do anything for their aortic pressure. So sodium nitrite, nitroprusside. Hydralazine should be avoided. Drops their pressure too fast. And then surgical repair is what we're doing. All right. 5 minutes left. Now this is just fun. This is just, we're going to look at some x-rays just to kind of, I don't think you're going to be tested on anything about this. This is just when you're in your clinicals and they're like, oh, look at this CAT scan. And then you see this little line and you're like, oh, I know what that is. We have a problem. So you could look all big and like you know what you're talking about. Or you can just pretend and, but anyways, you're looking for that line. You see how well those vessels are lit up? That's the contrast. You don't get that without contrast, okay? There's that false lumen, all right? That's the line we're talking about with the true lumen, false lumen, okay? So, what vessel is this? Where's it at?
Point to it, because I don't think they know where
Can you
you're
guys see
at.
it?
See the false
I
lumen?
asked Dan, I'm like, is this to throw at him or what is this for? Okay, so here's your spine, right? Here's the vessel here. And then it's way up in the front. An arch, aortic arch.
Very good, very good.
Yep, coming off the heart. Here's an aortic arch. Look at that sagittal view. We can really see it there, can't you? So it's right in front of the spine, so it's a, yep, abdominal, right? It's into my back. Here's a really good labeled one. There's the true lumen, and there's the false lumen. Look how small the true lumen is. We have problems. We have big problems. We have a patient that's fixing to die, okay? So this is a patient whose blood pressure has not been managed well, okay? So our pressure is too high. We need to get that false lumen down, and he needs to be he or she needs to be a surgery immediately. Here's another one. So when you're looking through these axial views, and you're like, what the heck am I looking at? Let me give you a little bit of anatomy here. Forget, I'm sorry. I'm going to stop me. So this is your lungs. These are all your vessels, your capillary beds. Okay? What's this? Yep, that's your carina, or your bronchial. Right? And here's your vessel. And here's your dissection. Okay? Remember, this is an axial image. This is just a slice. This is one slice. That's it. Okay? It's like taking a snap picture of a 2-hour movie And you have to figure out what's going on in that movie from one picture. Can't do that. Okay? Unless you've seen the movie, then you know what's going on. All right. X-rays. So this is a normal chest X-ray. Okay? So there are 12 steps to reading the chest X-ray. I'm not going to go over all 12 of them. I'm going to get the highlights related to what I'm talking about because that's all I care about. You're not going to learn all that stuff later. No. All right, here's your aortic knob. You guys see it right there?
Yeah.
You want to see that in every PA view of chest that you look at. Okay? Very important that you see that. How do I know that this X-ray is straight? You look at the clavicles. Who said that? Good job. Whoever said that. I don't know who said that.
Put your hand down.
Nobody
I said it first.
You look at your clavicles and you want to make sure, that the clavicles are lined up. You don't want to make sure one's higher than the other or it's funny looking, square. You also want to make sure you have good penetration and you can see the spine. There needs to be adequate penetration to see the spine. Okay? That tells you that the X-ray is right, the patient is positioned right, and that the penetration that the X-ray tech did is correct. If you cannot see the spine, tell them to redo it. Okay? What's this?
The gastric bubble.
Yeah, that's exactly. Normal gastric bubble. Okay? So this is normal. You're going to see a lot of normals. All right, so I left the normal up there for comparison. This is the patient that comes in with chest pain, and you're doing your cardiac workup, and you get this chest X-ray back, and you're like, oh, I think you're having a heart attack. And, you know, we'll get the weight on the enzymes, and you get this X-ray, and the X-ray tech comes and finds you and goes, this don't look right. And you go, nope, that don't look right. So, do we have an aortic knob? No. No. Can we make out anything? No. But you can see the spine, right? So there's adequate penetration. So we have a wide medial sinus. What do we order? What's next step? CT, that's right. Do the CAT scanner. All right, normal again. Normal on the left. Bad stuff going on the right.
Is that calcification?
Yes, that's exactly what that is. Good job. Calcified aorta. All right, it just lights up. I mean, it's like it just gives you a perfect outline of this thing. Because of course, bones show up good on X-ray, right? So calcified aortas do as well. This is called a calcium sign. You see this perfect circle? Okay. Yeah, there it is. See that perfect circle? You see that perfect circle?
Yes.
Thoracic aneurysm. Equal. Same. Every time you see it, that's what it is. Okay? But you're looking for the calcification of it. You're not, now you see a calcification over here, don't say thoracic aneurysm. Okay? The reason why it's a thoracic aneurysm because it's off of the aortic arch. That's where the aortic arch should be. Right? That's why I'm saying that. You see the difference?
Just like the rhino disc place.
It's hard to say, to be honest with you. Yes and no. But I would say a little bit. It's not to the point of like pneumothorax or something like that. But yes, there's a little bit of displacement there. Good eye. Normal again, abnormal. Do we have an aortic knob? Can we really make out the wall of the heart? So you see how it's well defined here? Well defined here. And you've got this, it's not as well. Okay. Now, can you see this? You see these little wires?
Yeah.
All right. Anytime you see these little wires, these are sternal wires from an open chest procedure. So when you get your chest sawed open and they open your chest and work on your heart, the way they close it is with those wires. So those will forever be in there. So anybody who's had a bypass or any kind of heart procedure, you're going to see those. But what's more specific is, remember that cartoon illustration of the stenoid? All right, here it is right here. See how it lines up, or lights up on the x-ray? So it has it here. So again, here's another one. Aortic aneurysm. See there's no aortic knob there. Okay? Got to get a chest x-ray. We made it. 3 minutes past. All right, what questions? Nobody fell asleep. Saw a few people drift off it. My numbers are good. I'm back Thursday. Y'all are stuck with me again. We're going to do Venus. But it's at noon, all right, or some earlier. It's not the later one. Y'all have a great day. Thank you. In the noon.
I'll be at the same table. I looked at her and I was like, you don't know. Yeah,
I am starving.
They're right over here by the basketball courts. I'll get my meeting cards from you tomorrow. Here, okay. They're out of the building. I'm gonna go. It's not even on. I can't just sit in it. Okay. Bye. See you girls later. Bye.